Hello dear viewers, in this video I am going to discuss oxygenation through high flow nasal cannula in adults. Here I will discuss when to use this mode of oxygenation and when not to use. I will discuss up-to-date literature regarding this modality in ICU setting. I am Dr. Sunil Garg from Essentials of Acute Care. Before discussing high flow nasal system, we will briefly look into conventional oxygen delivery systems. Broadly, conventional oxygen delivery system can be categorized into two. One is low flow system, which is delivered through either nasal cannula or face mask. Another category is high flow system, which consists of either venturi mask or non-rebreather mask. Though the conventional oxygen delivery system has been in use for long time, but there are some problems with the use of these modes of oxygen delivery systems. They do not deliver a reliable fraction of inspired oxygen, as we will discuss later in this video. In terms of reliable delivery of FiO2, HFNC performs better than conventional oxygen delivery systems. Another important problem with conventional oxygen delivery systems are that they are generally poorly tolerated by patients if used for prolonged period due to inadequate warming and humidification of inspired gas. HFNC provides warm and humidified air, so patients tolerate it well if oxygen is delivered for a prolonged period. The mechanism of clinical benefits of high-flow nasal cannula are multiple. HFNC provides improved comfort to patients due to its soft pliable nasal prongs and warm and humidified oxygen it provides. Increased humidification results in increased water content in mucus, which can facilitate secretion removal and may also decrease the work of breathing and avoid airway desiccation and epithelial injury. The washout of upper airway dead space improves the efficiency of ventilation and enhances oxygen delivery. HFNC increases nasopharyngeal airway pressure that peaks at the end of expiration. It means it creates PEEP effect. For every increase of 10 liters per minute of flow yields approximately 0.7 centimeter of water of airway pressure with closed mouth. So it can potentially unload auto PEEP if it is present, decreases work of breathing, and enhances oxygenation in patients with alveolar filling disease such as congestive heart failure or the acute respiratory distress syndrome. HFNC delivers more accurate concentration of oxygen due to minimal entrainment of room air because of high flow, and additionally HFNC decreases inspiratory efforts. While setting high flow nasal cannula, there are mainly two settings. One is flow and other is FiO2. We initially set flow and then FiO2. Initial flow setting is usually kept between 20 to 35 liters per minute, while the complete flow range is 5 to 60 liters per minute. FiO2 is set to achieve the desired target peripheral saturation. The flow rate can subsequently be increased in 5 to 10 liters per minute increment if the respiratory rate fails to improve, oxygenation fails to adequately improve, or breathing remains labored. It is preferable to maximize the flow rate first in an attempt to keep the FiO2 less than 60% if patients tolerate it well. However, an increase in FiO2 may be necessary to achieve adequate oxygenation. Patient should be switched to conventional low-flow nasal cannula system once the flow rate reaches 20 liters per minute or less and FiO2 50% or less. Despite limited data and the indication of its use are not absolute, HFNC is frequently used in clinical practice. HFNC failed to consistently demonstrate an improvement in clinically meaningful outcomes like mortality, intubation rates, and length of stay. The main use of HFNC is to provide a relatively high FiO2 to patients with severe non-hypercapnic hypoxemic respiratory failure from medical causes. Means when the PaO2 FiO2 ratio is less than 300 mm of mercury, It is suggested as an alternative to other means of delivering high FiO2 in such patients. It may be used as an alternative to NIV or for the provision of adequate oxygenation during breaks from NIV. It is also used for intubation and extubation support, as well as for the treatment and prevention of post-operative respiratory failure and for oxygenating patients during weaning trial or bronchoscopy. Although not routine, HFNC is an acceptable way to provide oxygen to patients undergoing intubation, both before procedure, like for the pre-oxygenation purpose, and during the procedure to prevent desaturation. While comparing high-flow nasal cannula with non-invasive ventilation, choosing between these two options depend upon factors including need for ventilation and positive and expiratory pressure, as well as patient preference and the tolerance of the NIV mask. HFNC is unlikely to provide sufficient PEEP for those who need it, like patients with moderate to severe ARDS. HFNC also cannot be used for those who require NIV for ventilation, like patients with hypercapnic, hypoxemic respiratory failure due to hypoventilation. And it is also unlikely to reduce the work of breathing as effectively as non-invasive ventilation. When not to use high-flow nasal cannula. High-flow nasal cannula does not have a role to play for those who are sufficiently oxygenated with low-flow nasal cannula or those with an indication for immediate intubation, which includes failure of non-invasive ventilation as well. Whenever there is contraindication like abnormalities or surgery of the face, nose or airway that preclude an appropriate fitting nasal cannula, or if complication arises like abdominal distension, aspiration, and rarely barotrauma. However, the risk of barotrauma is likely lower with the high-flow nasal cannula than with the non-invasive ventilation or mechanical ventilation following endotracheal intubation. As with any other therapy, patients should be monitored during HFNC therapy, and it includes not only monitoring of respiratory rate and breathing pattern, but the response of HFNC in terms of improvement in respiratory rate, breathing pattern, and oxygenation. During therapy with HFNC, ROX or ROX index can be monitored. The ROX index defined as the ratio of oxygen saturation as measured by pulse oximetry to FiO2, and this value is expressed as percentage to respiratory rate. It has only moderate discrimination power to predict the need of intubation in patient receiving HFNC oxygen therapy. The ROX index cannot be used in isolation and must be augmented by clinical judgment. Here I finish. Thanks for watching this video, and please do not forget to subscribe to this channel. I would appreciate your feedback, suggestions or comments. See you again in my next video on how I ventilate patient with ARDS. Till then, bye and take care.